Hi, I'm Randy Burd. I'm the Chief of the Division of Trauma and Burn Surgery at Children's National Medical Center. I want to take a few minutes to give an update on a few things in pediatric trauma. The world of trauma is constantly evolving, and there's some recent changes that I think I'd like to highlight for this talk. Most of the changes that I'm going to be talking about will be coming from the update of the ATLS manual. And I think these changes really have been a marked improvement for the care of injured children and injured adults. First is the ATLS manual has emphasized a few concepts about initial fluid resuscitation. It's brought in the concept of using a judicious approach to crystalloid administration. Studies in adults show that excessive crystalloid administration in patients who require resuscitation in the trauma bay lead to adverse outcomes. And so a judicious approach to crystalloid administration is warranted by extension, likely in kids too. The second concept here is a related concept is that early transfusion is essential in injured patients. So I think the general guidelines to use, as opposed to in the past giving the equivalent of 2 liters of crystalloid to patients who are hypotensive, 20 milligrams per kilogram, and kids less than 40 kilograms or a liter in older kids. Instead, a single bolus of crystalloid should prompt an early decision to give blood products. I think this is a critical way that we need to be thinking about things now. And the justification for this is really from studies that have been done mostly in adults. It's very hard to perform these kind of studies in kids. If you look at the change in mortality related to a simple 10-minute delay in administering blood to adult patients who need blood, or getting massive transfusion protocol activated in adults who need the massive transfusion protocol, that 10-minute delay leads to a change in odds of death of 27% in those who receive blood and 63% in those who receive massive blood transfusion. It's important to think about how these odds translate into actual changes in mortality. How does a 10-minute delay translate into a change in mortality? Well, it depends on what your baseline mortality is. If your baseline mortality is low, less than 5%, then that change is relatively small. But if you have a patient who comes in as severely injured with baseline mortality of 20%, that delay in getting packed red cells or getting massive blood transfusion, you have between roughly 5 to 10% increase in mortality. That's a significant delay. And delays that extend past 10 minutes lead to a further increase in overall mortality. So getting blood in early, avoiding crystalloid is essential. A lot of talk about plasma to red cell ratios in whole blood. And let me just make a few comments about that. Is that if you're giving a lot of blood, probably more than a unit of blood, you need to be thinking about giving yellow products. You need to be thinking about giving plasma. You need to be thinking about giving platelets. And so there's 2 ways to do that. You can either give that as component therapy, or you can give it as whole blood. Studies in adults suggest, and there's a few studies in kids, suggest that high plasma to red cell ratios improve overall outcomes. But the studies really showing the benefit of these high ratios, or even of whole blood, these studies still need to be performed in kids. And there's several challenges to performing these kinds of studies in kids. First, that there may be differences in the age group response to component therapy. Severe brain injury is pretty common in kids and has to be very carefully controlled for when looking at outcomes such as mortality. And you have to really very carefully look at adherence to transfusion protocols when studying the impact of component therapy. Our group and others are very interested in this, and I think that we'll see some nice studies performed to address whether or not this is a strategy. I think in the meantime, that if you have whole blood, it's a great product to use as the initial resuscitation blood product, and that if you're giving a lot of blood, you should use additional yellow products, plasma, platelets. Another recommendation in ATLS is the use of TXA, and the ATLS manual comes out with a pretty strong statement that in patients who are bleeding, who require blood resuscitation, should be given TXA within 3 hours of injury. And the dosage recommendations that I have listed here are based on a survey of pediatric trauma centers who have used TXA. And so I think the initial dose would be 15 milligrams per kilogram over 10 minutes, and then follow that up with an infusion of 2 milligrams per kilogram per hour over the next 8 hours. So I think, again, any patient that you're giving blood to, that I think it's reasonable to give TXA. We don't know if this will have a mortality benefit in kids. There's a few studies that are now being proposed to address this issue. I think that the complication rate is pretty small in kids based on experience with given TXA in other contexts like cardiac surgery and spine surgery. So I think that it's a reasonable option in patients who are bleeding. ATLS has changed terminology from rapid sequence intubation to instead using the terminology of drug-assisted intubation. And the terminology change is really to focus on a couple basic concepts. One is that pre-oxygenation is for all these methodologies is critically important. And the second is that you want the time to properly intubate the patient. So there's some patients that require a classic RSI sequence with sedation and paralysis, but there's other patients that can have a more focused drug-assisted intubation without the use of a paralytic. And I think the way to think about this concept and these terminology is drug-assisted intubation is this large group, and the classic approach which has been proposed for kids and adults in trauma setting is rapid sequence intubation. This is really a subset of DAI. Comment about needle chest decompression, and I'll get into this a little bit more when I talk about cardiac arrest, is the best approach for chest decompression in a patient with a potential tension pneumothorax in children, older children, and adults is not using the mid-clavicular line, but instead using the mid-axillary line in the fifth intercostal space. This recommendation comes from cadaver studies, which showed that the distance between the skin and the pleural cavity and the ease of access. For younger kids, you should still use the second intercostal space in the mid-clavicular line. So this is an important change, and I'll talk about how chest decompression could vary in the setting of cardiac arrest. On a related note, the idea of using EFAST for identifying pneumothorax has been highlighted. Classically, FAST is looking at the cardiac window and abdominal and pelvic windows. But the concept being promoted is to use EFAST for looking for pneumothorax. And there's a few caveats. And there's been some criticism of using EFAST for identifying pneumothorax. This is probably because this has been done in the context of retrospective studies that haven't carefully looked at how people have actually performed the ultrasound evaluation of the chest. And there's a few key points that if you're going to be doing EFAST for pneumothorax, you need to explore all anterior and lateral surfaces of the chest, and then need to look for the two findings which suggest the presence of a pneumothorax. One is the absence of the sliding sign, which occurs in normal lung, and the second is the lung point that occurs in the setting of pneumothorax. So I think this is a good and rapid test for diagnosing pneumothorax, and in most centers can be performed quicker than chest X-ray, but you need to be doing it with the proper technique. ATLS is no longer recommending prostate palpation as a way, as a diagnostic modality, as a way of diagnosing urethral disruption in particular. If you've been doing this examination, you probably can omit it from your standard evaluation or even your focused evaluation for select patients. This test has a high false positive rate, and the finding of a high riding prostate is influenced by Not surprising, the length of the examiner's finger, as well as the size of the patient. So obese patients will be more likely to have a false positive evaluation. It's really probably sufficient to just use clinical criteria to determine whether the patient has a urethral disruption or a significant perineal injury. And those findings are things like blood at the urethral meatus, unstable pelvis, and scrotal hematoma. So I think this if you have this as part of your evaluation, it probably can be omitted. Specific recommendations have been added about management of pelvic fracture associated with hemorrhagic shock. Some of these things are things that we would do all the time. And this is the algorithm from the ATLS manual. So you basically, in a patient who is in shock, do something to stabilize the pelvis with a pelvic wrap using a sheet or devices that are designed for that purpose. And then ask the question, if the patient has intraperineal blood, then that patient should undergo a laparotomy. If the patient doesn't have intraperineal blood, there's now the option of using peritoneal packing that's offered in this algorithm. It's a modality that can bridge the time gap between patient arrival and getting the angiography team available in your hospital. Not all hospitals have an in-hospital angiography team or angiography suite that's immediately available to trauma patients. And so a visit to the operating room with peritoneal packing is an option. A few comments about the spine and spinal cord trauma. The terminology of C-spine protection is changed to restriction of spinal motion. The concept here is to focus on really what's important. It's really the neck not moving, and that should be the focus of the cervical spine stabilization. The ATLS manual now highlights getting off the backboard rapidly. Instead of using the backboard as a mode of transportation for patients throughout the hospital, get them off the backboard early. Backboards have been associated with several complications which can confound the initial evaluation of the patient, including worsened respiratory distress by being on the backboard, increased pain from being on the backboard, and for patients who are on for a significant period of time, even pressure sores have been reported. Cervical spine imaging, few recommendations. The new recommendations are to add the consideration of the nexus in the Canadian C-spine rules and helping to decide whether or not patients should undergo cervical spine imaging. The pediatric emergency medicine network has an ongoing study evaluating different criteria for determining whether or not cervical imaging should be performed. And there are 7 criteria are listed here. Most of these are things that we use in common practice, but if you haven't incorporated these into your pediatric C-spine algorithms, it's something to consider. The ATLS manual now strongly recommends the use of the PCARN criteria for head CT imaging, and presented is a symbol graphic here. There's two flow charts, one for kids who are less than 2, one for kids who are older than 2. And it basically starts if you have ultramental status, low GCS, some kind of skull fracture, either a palpable skull fracture or a basilar skull fracture. If you have those things, then you move on into the next set of criteria, which is a combination of clinical findings and clinical symptoms. And using this algorithm, it's pretty accurate for determining patients who don't need a head CT and determining the need for a head CT evaluation in patients who have equivocal findings. Another key part of the ATLS manual is about referral hospitals. There's been a lot written about excessive imaging of kids in particular, but overall in all trauma patients. And the ATLS group has now recommended avoiding CT in the primary hospital. So this doesn't mean that you shouldn't perform diagnostic procedures that that will impact the patient's care. This doesn't mean that you shouldn't perform CT scans or other evaluations if the patient's transport is significantly delayed, but the concept is that moving the patient forward in the treatment path from the referral hospital to the recipient hospital should be a priority at referral hospitals. ATLS now has a nicely outlined algorithm for cardiac arrest. And a few key points about this algorithm. If you haven't taken a look at this algorithm, it's worth taking a look at because I think it nicely summarizes the approach to these patients. It doesn't really address who should undergo ED thoracotomy, but it gives an overall outline of a common procedure for those who you determine should undergo that procedure. A few key points is that the algorithm is the same for patients with penetrating and blunt injuries. There's no differentiation between these two mechanisms. There's a focus on rapid stabilization using airway placement, intravenous catheter or IO catheter placement, administration of emergency medications like epinephrine. All these rapid stabilization procedures, pushing you to perform these within 2 minutes. If there's no response and there's no return of spontaneous circulation, then bilateral chest decompression is recommended. And the approach recommended is not with needles, but instead using the finger thoracoscopy approach, or tube thoracoscopy approach. Because these patients are in cardiac arrest, these don't need local anesthesia and should be done rather quickly. And the time course that they recommend proceeding from a patient arrival to ED thoracotomy is less than 3 minutes. And in freestanding pediatric hospitals that don't see a lot of patients in cardiac arrest, this is a real challenge. But this is the guidelines that are recommended for cardiac arrest. A few things about ATLS is now recommended about GCS calculation. It's really sort of a clarification rather than a change. And these are kind of important terminology things. So let's go through a few things. Instead of speech, the eye opening and verbal response triggers are to sound. The pain elicitation is made more explicit. For eye opening, it's to pressure rather than leaving it more vague for interpretation of what pain administration is. And then some of the terminology about abnormal reflexes have been cleaned up. There's also been the addition of a non-testable category. So patients that are not evaluable, including that in each of the 3 components. And the final recommendation is, and this is something that we do in our trauma bay, is to report all 3 components of the GCS. We found it's not terribly useful sometimes to simply say the GCS is 9, but instead to say what the individual components are and how they were constructed provides more valuable information to the team, and ATLS is now recommending that approach. Burn resuscitation. Some minor changes here. For older patients and adults, the initial fluid rate should be 2 cc's of LR per kilogram per percent total body surface area burned. In younger children, that number is bumped up to 3 cc's per kilogram per percent total body surface area burned. And in kids, the young infants and young children, kids less than 30 kilograms is maybe a good threshold to use, is you should add some sugar-containing solution to the resuscitation. Children have poor glycogen reserves and can become profoundly hypoglycemic during the resuscitation period if added glucose is not included in the resuscitation. And finally, all patients, all ages, who have significant electrical injuries should be bumped up in their initial fluid resuscitation volume to 4 cc's per kilogram per percent total body surface area burned. And then urine output thresholds is sort of the standard strategy for resuscitation. And I just want to finish up with changes in the CDC triage guidelines. So in 2021, an expert panel published their revisions to the pre-existing field triage guidelines for injured patients. This was published in the Journal of Surgery, and I think there's several remarkable differences that are in the guidelines for kids. One is the definition of hypotension for kids. So this really wasn't explicitly given in the previous guidelines. And there's the formula for kids less than 10 years of age is if the systolic blood pressure is less than 70 plus 2 times the age in years. A pretty quick and easy formula to calculate. Kids older than 10, the threshold of 90, just like in adults, is used. But there was also the addition of the shock index. And so the shock index is the ratio of heart rate to systolic blood pressure. And when that ratio is greater than 1, those patients also should be considered to be hypotensive and warrant triage to a trauma center. A few clarifications and additions to the mechanism of injury criteria. The addition of a child unrestrained or unsecured in the child safety seat. This is where you see the kid in the car seat, where the car seat is flying around, but the kid is in the car seat. Not an uncommon scenario that we see in pediatric trauma. This has been added. There's a clarification about falls in 2 categories. One is that low-level falls in young kids, defined as less than 5 years of age, who also have significant trauma. Those kids should go to a trauma center. There's a similar recommendation for elderly patients. And these 2 groups, the very young and the very old, are those that are at increased risk for intracranial injury despite a low-level fall. And then fall from height used to be either greater than 10 feet or 2 to 3 times the height of the kid. The metric has now been simplified to be greater than 10 feet for all ages, rather than this 2 to 3 times the height of the kid. And then all of us would agree that suspicion of child abuse in any child less than 5 years of age, that kid should go to a trauma center. And so I'll stop here. Thank you for your attention. I hope these comments were useful for your practice, and I look forward to your feedback and questions. Thank you.